to AETCM, the emergency medicine channel. Today, let us discuss about facial nerve, one of the important nerve which we have to examine in our clinics. Many patients can come with facial nerve palsy. It can be a part of a stroke. It can be part of brainstem disease. It can be a part of like peripheral nerve, that is Bell's palsy. Like various presentations can be there. We'll see how to differentiate all these things. The voluntary response from the face, like smiling, movement of the facial muscles, all these movements are controlled from a discharge from the motor face area in the cerebral cortex. You can see the diagram here. This area controls our face, especially on the opposite aspect of the opposite side of the face. That is very important. The motor face area is situated on the precentral and post-central gyri. So if you know the anatomy, you'll know where it is situated. Whatever it is, the facial expression on the opposite side will be controlled by this area. Okay, so that is very important. Now, if you see the nuclei, facial nuclei in pons, there are multiple areas in that nuclei itself. There is a motor nucleus that controls the movement of the facial muscles in pons that supply the motor fibers. So, motor nucleus, you can see here, this is the motor nucleus that controls the facial muscles. Then there is superior salivary nucleus that controls the parasympathetic component of the nervous intermediates, and nucleus of solitaris and tractus that is seen in the medulla, that receives the sensory component mainly from the tongue. But normally when we are examining the patient, we mostly examine the facial muscles. So motor nucleus only we are examining clinically. But if you have time, you also have to examine the sensory part of the facial nerve. Now, when you discuss the anatomy, you can see here this seventh cranial nerve hooks around the sixth cranial nerve and comes out. And here it is with the facial nerve is coming out with nervus intermedius. So these are the nuclei you can see here: superior salivary nucleus and tractus of solitaris, and facial nerve nucleus that hooks around the sixth nerve and comes out from the brainstem. So it leaves the brainstem at pontomedullary junction. So these are anatomies. These are we should know all these things before we go to the proper examination. Again, the salivary glands like submandibular and sublingual glands, and sensory from the tongue. All these things are also will be controlled by facial nerve. So here you can see the diagram. Cauda tympani nerve contains both parasympathetic efferent and visceral efferent nerve fibers. So that controls your salivation and taste sensation from the anterior two-third of the tongue. That is also very important. Now, motor examination, we will see in detail each muscle how to examine. We will see in the subsequent slides. This is a list of muscles we have to examine. We will see each one by one. So, first muscle is occipitofrontalis muscles. You can see here occipitofrontalis muscle. These are the occipitofrontalis muscles. So, ask the patient to look up. You can see the wrinkles. You can see the wrinkles on the forehead. That is a normal function of whenever the muscles are contracted, you can see the wrinkles on the forehead. Suppose one side of the facial muscles are not working, or if they are weak, facial palsy is there, like Bell's palsy, that side you will not be able to see any wrinkles. That is very important. Facial nerve palsy produced by Bell's palsy, that is element type of palsy, upper part of the face is also involved. So this is the first examination you have to ask the patient to look upwards or wrinkle the forehead. You are testing occipitofrontalis muscles. Next muscle will be ask the patient to tightly close his eyes. You are testing orbicularis oculi. And you can see here the patient has closed his eyes. Forcefully, examiner try to open the eyelid. So normally we will not be able to open the eyelids with a moderate force. But in facial nerve palsy, on that side, you can see that the eyelids are not closed properly, and you can see the eyeballs rolling upwards. This condition is called as Bell's phenomenon that we'll see afterwards. So ask the patient to tightly close his eyes. Examiner will try to open the eyelids. Normally, examiner will not be able to open the eyelids, but if the facial palsy is there, either patient will not be able to close the eyelid on that side, or it will be very easy to open the eyelids for the examiner. So we are testing orbicularis oculi. The next muscle is purse lip or whistling movement of whistling movement. We are testing the orbicularis oris. You can test like that. Patient is trying to close the mouth. Examiner will try to open the mouth. If you are trying to whistling, if the patient is trying for whistling, you can see one side will not be closed properly. So one side will not be closed properly, through that air will come out. Okay. So that also you can test, that is orbicularis oris, the muscle around the oral cavity, that is orbicularis oris. That muscle also controlled by facial nerve. Now ask the patient to blow the cheek. This is another test. You are testing the buccinator muscle. Here you can see the buccinator muscle. You ask the patient to blow like this. So both sides will be blown out. But if there is a weakness on one side, when you tap on that side, very easily you can deflate that part and air will come out through that part. So that we are testing buccinator muscle. So that also contributes the facial muscle movement by facial nerve. Now next is to show the teeth or smile. We are testing two muscles, levator angularis, that is this muscle, and risorius, that is this muscle. Patient will be able to show his teeth like this. Suppose there is a weakness of one side. Normally it will be, when you ask the patient to smile, it will be equal, both sides it will be equal. But suppose there is one side weakness, for example, this side is weak. These muscles are not acting properly, so the mouth will deviate to the opposite side. That is very important. Weak muscle will not work, and the other muscle, which are normal, they act very strongly, and the mouth will be completely deviated to opposite side. So the deviation of mouth will be always towards the normal side here, because of the facial muscles are weak on the side of the weakness. Now you can, next examination will be pull down the corners of mouth and wrinkle the skin of the neck. We are testing the platysma muscle. So platysma muscle we are testing here. You can ask the patient to do like this. So suppose there is weakness on one side, that side will not be moving downwards, other side will move, and the movement will be exaggerated on that side. We are testing muscle, that is platysma. Now sensory part, ideally we have to hold the tongue like this and keep the tongue outside. Put a drop of seed solution or sugar solution or bitter solution like that. But it is very difficult to do that test. It's a cumbersome procedure. So we try to avoid this type of test. If you want to test one or two taste like sugar solution, you can put on one side of the tongue and ask the patient to wash his mouth. Again, put it on the other side. You can check the taste. And testing all these things will be very, very difficult. Now, corneal reflex is another important reflex you can examine. Here, we are testing both the nerves. The sensation is taken to the brain by 5th cranial nerve, and the closure of the eyelid will be produced by the 7th cranial nerve. You ask the patient to look away from the cotton swab. You are touching the eyelids, and ask the patient to look away and down, up. Sorry, it is here the patient will be looking medially and upwards so that the eyes will be opened properly. The examiner will try to touch on the lateral aspects of the eyes without going in front of the middle part of the eye so that he will not be seeing the cotton wool. And when you touch on the this one eyelid, sorry, in the eyes, the sensation will be taken from the eyes to the uh, center in the brain through the fifth cranial nerve, and the motor response will be coming to the eyelids so that eyelids will try to close. That is a protective phenomenon. That response try to protect the eyes from external injury. Okay, so fifth cranial nerve carries the sensation to the brain, and there will be a sender. From there, seventh cranial nerve try to close the eyelids. So that is a test for the sensation in the eyes. This is called as blink response or blink test. So that also should be done to know the sensation in the face. We are testing two nerves, that is fifth and seventh cranial nerve. Now another test, you can see the like salivation and lacrimation. You can do the shimmer test, that routinely done in ophthalmology, but you can also try to do this test. You are actually assessing the secretions from the eyelids. Normal range is 15 to 25 millimeter in the paper. Okay, so that can be done in a routine clinic, or normally it is done in ophthalmology clinics. Now, one important thing we should remember is how to differentiate between UMN and LMN type of palsy. UMN means upper motor neuron type of facial palsy. Upper motor neuron type means it is always associated, mostly it is associated with a stroke, like right-sided cortical infarct will produce left-sided weakness. Along with that, patient can have left-sided facial palsy also. That is very important. Right-sided lesion can produce left-sided upper limb, lower limb weakness. Along with that, patient can have left-sided facial weakness. Most of these lesions, upper part of the face, that means forehead, will be relatively spared, because upper part of the face has got bilateral innervation from the right side and left side of the brain. There will be innervation. So a lesion which is only from the right side, upper part of the face will not be involved, or they are relatively spared. In a severe type of stroke, even upper part also sometimes involved. So that is very important to remember that anatomy. Right side lesion can produce left-sided upper limb, lower limb weakness, and left-sided facial involvement. In that left-sided facial involvement will be only lower part of the face. This is called as UMN type of facial palsy. We will see how you differentiate these two things. LMN palsy means from the brainstem, especially from the pons, you can have a lesion and the face will be involved on the same side. Suppose right-sided pontine lesion, whole right face will be involved, pontine or outside the pons. That is, the cranial nerve as such is involved. Their whole right side is involved. Both upper part and lower part will be involved. So here, human type of facial palsy, only lower part of the face will be involved. You can draw here. You can see here. So there is, suppose there is a right-sided stroke. So left side patient, sorry, this is the left-sided stroke, left side upper limb and left side lower limb will be involved, and left side of the face also involved on the lower part. So only lower part of the face is involved, and that too, that will be on the opposite side. Whereas in LMN type of facial palsy, so from the pons or in the cranial nerve itself, from the right side it is coming. Both right side, upper and lower part of the face is involved. So that is the most important finding you are going to see between LMN facial palsy and UMN facial palsy. LMN facial palsy means the whole face is involved, whole upper part and lower part of the face is involved. Whereas in UMN facial palsy, upper part is relatively spared. Now, next one is Bell's phenomenon. Bell's phenomenon means When we are trying to close our eyelid, when you are trying to close your eyelid, normally your eyeballs roll upwards. That is a normal phenomenon. We are not seeing that because we are closing our eyelid like this. Suppose we are not able to close the eyelid because of facial palsy. So when you are trying to close the eyelid, normally eyeball from here, it moves upwards and you are not able to close the eyelid. So what happens? You can see the eyeball is rolling upwards. So this is a normal phenomenon occurring, but we are seeing that it is very visible to us because the patient is not able to close his eyelids. So that phenomenon is called as Bell's phenomenon. When the upper part of the face is relatively spared, you cannot see the Bell's phenomenon because in human type of facial palsy, patient will be able to close the eyelids. So you cannot see the Bell's phenomenon. Whereas in element palsy, patient is not able to close the eyelids. So you can see the Bell's phenomenon or you can see the uprolling of the eyelid. And another thing I have already told, cranial nerve palsy, that is a seventh cranial nerve and the hemiplegia on the opposite side. So brain, there is a lesion. So opposite side of the brain, face is involved and opposite side of the body is also involved. Upper limb and lower limb is involved. Whereas in seventh cranial nerve in the pontine area or in the peripheral nerve as such, the same side of the facial nerve, same side of the face, and if it is in a pontine lesion, same side weakness also can occur. So that is also you should remember. Now, emotion is preserved in bilateral human palsy, but element facial palsy, emotion also absent because all fibers, including the facial nerve fiber, secretory fiber, emotional fibers, everything is coming through the peripheral nerve. If peripheral nerves are involved, even emotions on that side will be completely absent. So that it is very difficult to identify in a unilateral facial palsy, but bilateral facial palsy, because of element palsy, it's a very rare phenomenon. You can see that emotions also will be absent in that area. Then this is, now you can see here, this is Bell's phenomenon. Bell's phenomenon is patient is trying to close the eyelid like this. Here patient is able to close. We are not seeing the eyeball rolling upwards. Here the patient is not able to close the eyelid because of the facial palsy. You can see the eyeball is rolling upwards. So this is called as Bell's phenomenon. So that Bell's phenomenon, should not mistake that with Bell's palsy and Bell's phenomenon. Bell's phenomenon is a problem what you are observing in element type of facial palsy. Bell's palsy is a element type of facial palsy. It is mostly produced by a virus, that is herpes virus, herpes simplex virus. Now this part we have already covered. Upper part of the face, it has got a bilateral innervation. Both sides of the brain innervate the upper part of the face from the same side, and from the opposite side there will be innervations. So that is very important. Upper part of the face has got bilateral innervation from the brain. That's why in UMN type of facial palsy, upper part will be relatively spared, because even if these fibers are cut, the opposite side brain can also give some innervation to upper part of the face. But whereas in element type of facial palsy, since everything is coming through the peripheral nerve, then you can get a complete palsy of that side, including the upper part of the face. So we have discussed about Bell's palsy or facial nerve palsy. Bell's palsy is a type of facial nerve palsy, type of element type of facial palsy that is produced by a virus. The treatment of Bell's palsy is antivirals, like you can give acyclovir. Some patients may require steroids, and physiotherapy also needed in Bell's palsy. Don't confuse with Bell's palsy to Bell's phenomenon. Bell's palsy is a type of element palsy produced by a virus, that is herpes simplex virus. Bell's phenomenon is a problem you are observing in a patient who is having element type of facial palsy. All types of element type of facial palsy you can see Bell's phenomenon. That is because we are not able to close the eyelid. You can see the eyeball rolling upwards. Thank you.